Right, thank you very much. I'll get cut to the chase. I'll keep it simple. I've intentionally left it just to preoperative planning because as a trainee, we haven't done much of these, and since I've been here, I'm actually doing more and more of these. These are my disclosures. A quick review, we're looking at the axis. We've got the mechanical axis, we've got the anatomical axis, we've got the deviation from these axes. We need to have some orientation lines which could be around the joint or beyond, and then we want to classify them and find out which ones are the normals. But the problem is we don't have any of these lines, or especially since I've tried to relearn all of this, I need to make my mind or my brain a bit more mathematical, and I can't do that if I don't have lines in the OR. So the plan is, I've learned it from these guys, Hemant Sharma, frame specialist, the lady, and the name escapes me, and Adrian Wilson, who's helping us with
Liz Mulder.
Liz Mulder. Liz, lovely Liz. She does kids and corrective osteotomies, and Prof helps me with my planning for osteotomy. So I send my stuff to him. So what I've learned from them is we go to measure the deformity, analyze the joint lines, and pick the bone that we're going to work on, map. We're going to ask ourselves, where is the deformity? Where should I cut the bone? And how am I going to correct it? Down to the basics, A, B, C. Apex of the deformity, which is the center of the deformity. And you can have a couple even more epices. Bone cut will depend on where you've decided to cut the bone. And it'll also depend on how well that part of the bone is going to heal under various factors. Correction, you go ahead and correct it. There are various ways of doing it, nails, plates, frames. You can go for gradual correction like Hemant Sharma does, and computer-assisted ones. So, center of gravity is the intersection of the proximal and distal axis, the angles created, and the apex marks where you're going to correct. And in these diagrams, that is about 10 degrees. Like I said, there could be various segments in each bone, but you've got to realize no matter how big the size of the segment is, there's always going to be an axis. How do I find the axis? So you've got the lines made. You identify the proximal and the distal segment, and that ends up being the apex. Axis planning. So what you're looking for is lines. So one's going through the long bone, so mid-diaphyseal. You look for a joint angle, hopefully it's normal to start with, and then define the bone or the segment above or below. And that's where you end up needing to think about corrections. The bone cut, so you've identified the level of osteotomy, and apex is the ideal location as to where you're going to do it. And you can decide on the techniques, and I leave the learned community to decide how they'd like to proceed with cutting the bone. Once we made the bone cut, you've got to decide how close to the apex you are. If the apex is at the osteotomy, then you get perfect alignment. Otherwise, you've got some translation and offset of the bones that you need to keep in mind. So we mark, just reiterating the fact because I need to dumb it down in my head. So mark the apex, perform the osteotomy at the apex, place a hinge at that apex, and perform the correction. So again, so you've got this position, you've got the mechanical axis, and you end up deciding where the apex is in this situation, and it looks like it's the distal femur, and it has been corrected to a desired alignment level. Right, we'll talk about these in a second because they confuse me anyway. So now what we're doing is we've done a preoperative plan and we're wanting to recreate that plan. And we want to predict any translation if there is going to be. Again, my problem is if it's not mathematical in my head, I don't know how am I going to reciprocate that when I get into the OR. So like this patient, he's a 45-year-old manual worker. He's got medial knee OA, and you've decided on something. You looked at the joints, and you've ended up giving them a high tibial osteotomy. So, looking at the deformity, whether it's in the tibia, whether it's in the femur, whether it's both, you're going to look for mechanical axis, anatomical axis, you're going to decide on the correction, and then you decide which implant you're going to put in. You're going to decide if you're going to use any bone grafts or substitutes. I don't have the luxury of standing long length views. Does anybody in the audience have access to them? Right, excellent, fantastic. We don't, so that's great. I can ask the general if I need to refer somebody for long length views. We don't have standing long length views, especially in my facility. Again, these dreaded lines, for some reason, it just doesn't get into my head. So we've got a mid-diaphyseal line, we've got mid-diaphyseal line distally, we've got a normal joint line angle, and I start making some angles, and I tend to pick a few. One of them is the medial proximal tibial angle, which is close to 90, and then the anatomic lateral distal femoral angle, or LDFA, which is 10 degrees less. I almost remember that because that's probably what I want to use when I'm in there. And their joint line convergence is nearly 0 degrees, which means that you can get an angle which is about 81 in the tibia and 82 in the femur, so that means the problem is in the tibial side. So okay, fantastic. So I've got that. Again, examples where you've got so you've got some lateral distal femoral angles that are made, but now you've got a joint line convergence, and your MPTA is less as well. So that means they may require a double osteotomy. Anatomic axis, for me, this gets way more confusing, but because we're discussing planning, I wanted to add these where you've got the femorotibial angle, which is 5 to 7 degrees. With your arthroplasty, you aim to overcorrect about 3 degrees, and because of that, you end up calculating a certain angle. This is reasonably important because you want to offload the area which is under stress, and there are various nomenclature, and you end up finding out if you're going to be shifting load, how much valgus or varus correction you would end up needing. This is quite useful because we end up using what we call the Fujisawa point, which is somewhere between 1575, 67.5 or whatever, and that people have found to be useful, which means that you've got a mechanical axis deviation or a plumb line, and you've made your angles. You've got the angle of correction, and that would be the desired angle of correction if you were using the Fujisawa point. Am I off time? Is it 10 minutes over?
No, they started at 5 minutes.
Right, so okay, right. So again, if it is more than 10 degrees, then you end up needing to do less correction, but the general rule, as they say, is a millimeter is a degree. So if you were thinking about 10 degrees, that's about 10 mils, or the size of a medium osteotome that I use. So what do I do in this? I end up getting a few of these. So this is a lady who's mid-40s. She's a widow, she's a school teacher, and she's got 3 kids. And I don't think she has enough money for me to offer a joint replacement surgery of whatever description. I don't have the luxury of having specific pre-contoured osteotomy plates. And I've put a blocking screw, and even then the fracture has propagated. But this is her 7 months down the line. I don't use bone graft, again for cost reasons as well. And I think at some point I do take this up to see that at 7 months it is filling up. We've still maintained certain joint line. The slope is maintained as well. So I end up just very quickly talking about preoperative planning. There's some cases where there's always debate, and I try to get help. I get it from Prof and his team in England, and you've got this lady with valgus deformity, and we want some corrections. And I don't have the software, but if I send it and email it through, he comes up with a plan for me to decide whether I'm just doing 1 bone, 2 bones, and which ones. So what I end up doing intraoperatively is I put an ECG lead, or that ECG sticker at the center of the ankle, and I've just got this diathermy lead that gives me an idea once I've done the correction. So this is the girl. Preoperatively, she does have scoliosis as well. She's got that lurch, and this is before she's getting married. She doesn't like the way this looks. She wants it correcting, and she was fairly engaged. And this is, I think, 3 months after surgery. But in summary, yes, the right patient, know where the deformity is, know where your axes are, how you're going to correct it, what implant you're going to use. I personally don't use bone graft. Thank you.
Thank you. Thank you very much.